afternoon اليوم راح تكون electrophysiology. We have two sessions on electrophysiology. The first one will be led by our elite electrophysiologists اللي معنا دكتور منير الزقة، دكتور باسل أبو الهيجة، ومعانا طبعا أستاذنا دكتور أيمن حمودة، ومعانا our research nurse فرح قطيشات. مظبوط، اهلا وسهلا فيكي. وفي برضه كمان lecture للدكتور رائد العوايشة supported by الدولية للدواء. So without any further delay, بدنا دكتور باسل أبو الهيجة to give us a lecture about indications for devices, particularly the TaskForce implementation of guidelines in Jordan, the challenges, the adaptations of the guideline, how is Jordan different in regards to devices. Dr. Basil Abu Haija, he is new to the country, but he has a very long experience in the US as a practitioner electrophysiologist, and he had spent a lot of time on the arrangement of this session and the coming session. So it's our pleasure to welcome Dr. Basil. Ahlan wa sahlan.
Thank you, Dr. Hammoudeh. If I'm inside. So I will talk about the indications for cardiac device implants. Basically, we're going to talk about pacemakers and ICDs in addition to CRTDs. Yani the watchman is not part of the protocol of the catheter inclusion devices. And based those next picture. So this is the EP session, and we are trying to have protocols that will be, inshallah, distributed to most centers in the country for device implants. Those protocols actually are from the guidelines, international guidelines, basically the American Heart Association, European Society of Cardiology, and the ACC. The latest guidelines, the Americans came out in 2018. The Europeans had an update in 2021. And I will go briefly about those guidelines. So those protocols and indications are based on clinical trials or clinical evidence. So they did many studies and they came out with those protocols. We will talk about pacemakers, ICDs, and CRTs. So I will start with each one, pacemaker indications. The two main categories for pacemaker implants are actually either failure of impulse initiation, and that's sinus node dysfunction, or failure of impulse conduction, and that's conduction system disease, whether it is at the level of the AV node or below it. And we'll start with sinus node dysfunction. This is actually the most common indication for cardiac device pacemaker implants, and it does increase with age. And the ECG manifestations can include, or the criteria are the following: either sinus bradycardia, heart rate less than 40 beats per minute with symptoms, underlying with symptoms, or sinus pauses or arrest more than 3 seconds with symptoms while awake. Because some people have pauses during sleep, they have sleep apnea, those are not indicated for pacemaker implants. In the case of AFib, the cutoff value is 5 seconds with symptoms. Sinus node chronotropic incompetence. It's very underdiagnosed, especially in our area, in this country. Chronotropic incompetence, there are many definitions, but the most commonly used definition is failure to achieve 85% of the maximum age-predicted heart rate, which is 220 minus age, and that's the most commonly used definition. There are other definitions, but most people rely on that. The symptoms of sinus node dysfunction can include dizziness, pre-syncope or syncope, fatigue, decreased exercise tolerance. So when somebody comes with fatigue, decreased exercise tolerance, we should always have this in the back of our mind. The second indication for pacemaker implant is AV block or conduction system disease. Third degree AV block, which is complete heart block. Some people call it high-grade AV block. Then second-degree AV block at or infrahessian level, which is type 2, and we will go over them quickly, or symptomatic type 1 second-degree AV block. Symptomatic first-degree AV block similar to those with pacemaker syndrome, because if a first-degree AV block, if the PR is very long, there would be some dyssynchrony between the atrial and ventricular contraction, just like with a single pacemaker ventricular relief. The last indication is alternating bundle branch block, which also falls under the category of conduction system disease. Those are just examples, and I'm sure you are all familiar with them. Third degree AV block, the first one, the atrial rate is going at 100 beats per minute, the ventricular rate is going maybe 7 beats per minute, and each is going at its own rate and own limit. And then second degree AV block, we have two types, type 2 and type 1. Type 2, that's a straight indication for pacemaker. Type 1, only if symptomatic is an indication for pacemaker. And differentiation between them is PR. In type 2, there is a sudden drop of the QRS complex without any PR prolongation. In type 1, there is PR prolongation before the next beat is not conducted, just like the third example. Now, post-MI AV block, I'm going to briefly talk about it because Dr. Mohammed will tell us more about the arrhythmias post-MI. However, I just want to say a couple of things. Complete heart block can complicate MI. And sometimes we wait 48 to 72 hours. It is inferior MI, but in the case of anterior MI, we usually don't wait and we just implant the pacemaker. And the reasoning behind that will be discussed or talked about in Dr. Mohammed for the post-MI arrhythmias. Now, next we're going to move to the ICD indications. So ICD is basically performed to prevent sudden cardiac death. And when we say sudden cardiac death, we have two main categories. First one is primary prevention, meaning that the patient never had sudden cardiac death due to VT or VF, but is at risk. The second one is secondary prevention. A patient experienced and survived sudden cardiac death due to ventricular arrhythmias or ventricular fibrillation. I will briefly go through the secondary prevention. So those who survived VT or VF or had a syncopal event that is strongly suspected to have been caused by ventricular arrhythmia and is also considered secondary prevention for SCD. This is a talk of debate and how do you say how do you really suspect VT or VF? It's basically the complete history and patient profile. So the ICD implantation is for secondary prevention is indicated regardless of the structural heart disease. In other words, some people have an ejection fraction of 40% and they have VT-VF level, they get an ICD. However, if there is a reversible cause, just like electrolyte disturbances or medications or some kind of VT that are treatable with ablation, then ICD should not be considered first if we can ablate that VT. Secondary prevention in coronary artery disease. I'm going to talk about the VTVF more than 48 hours after MI. Those patients should go under evaluation for ischemia before we plan the ICD. Let's say someone presented with an MI, after on the third day they get the VFVT, maybe they had a stent thrombosis again. So ischemia should be evaluated prior to planning an ICD. However, if coronary revascularization is not possible, then we proceed with an ICD. This is just a diagram to simplify what we just talked. VT or VF post-MI more than 48 hours. If there is ischemia, then we do revascularization. If there is no more ischemia and it's just a scar that's causing the VT, then ICD is indicated. Primary prevention, based on several trials, patients who have an ejection fraction of 35% or less with a New York Heart Association class of 2 or 3, or EF of 30% with coronary artery disease or prior MI, they should get a primary prevention ICD, provided that their anticipated survival is more than 1 year. So if their anticipated survival is less than 1 year, they should not get an ICD. Of course, anyone who gets a primary prevention ICD should be on guideline-directed medical therapy for at least 3 months before evaluation for placement and ICD. Now, the issue and one of the challenges, heart failure therapy is evolving, and the guideline medical therapy for heart failure in the past was beta blockers and ACE or ARB. Now we have SGLT2 inhibitors, ARNIs. So when someone presents to us, do we consider ACE and beta blockers are enough for GDMT, or should we say they are not on SGLT2 inhibitors? And actually the guidelines did not address that yet. As electrophysiologists, if someone is on ACE or ARB plus the appropriate beta blocker, we are considering the GDMT and they get an ICD. So this is, I think the guidelines should address, the new guidelines should address this. ICD therapy indicated for patients with MI who are not amenable to revascularization. However, in those people, we do not wait 3 months, we implant them after 40 days. And with patients who have ejection fraction more than 35%, but less than 40, and they have not sustained VT, we can justify an ICD, but we have to do an EP study and see if they have a usable VT. And this was studied and they showed there's mortality. Of course, in general, 90 days after revascularization, this rule is this rule stays. Now, how about non-ischemic cardiomyopathy? There was a debate a few years ago that ischemic and non-ischemic are not the same categories, and they did a couple of studies, like the definite studies and SCED trial, and both showed survival benefit for ICD for patients who have AEF of 35% or less, and New York Heart Association 2 or 3. So ischemic and non-ischemic, they do with ICDs. Those are just like the summary of the studies that prove mortality benefit for ICD implant. The most famous are the MADIT-1, MADIT-2 studies, and most of us are familiar with them. the skid heft are for the non-ischemic, but really the MADIT 1 and MADIT 2 are the two studies that showed the survival benefit of ICD implant or even CRT. There is primary prevention specific diseases that we don't see a lot. I'm not going to go deeply into them, and some of them actually are a matter of debate. But congenital long QT syndrome, CPVT, particularly Munir ventricular tachycardia, Rugada, arrhythmogenic right ventricular cardiomyopathy, HCM, myocardial sarcoidosis, for example. Someone with sarcoidosis presents with a heart block. And so we proceed with, not a pacemaker, we proceed with an ICD because those patients are at risk of developing arrhythmias. Instead of implanting an ICD today and then upgrading it in a year with the risk of infection, the guidelines say just go ahead and put an ICD. This is just a summary of those rare causes, and it is like sarcoidosis. If this is a 5%, it is appropriate to implant an ICD. If more may be appropriate, just like the example I said, may present to heart block, we proceed with ICD. Other diseases like pericardial cardiomyopathy, giant cell myocarditis, they all follow the same rule. Guideline medical therapy for 3 months, and then if the ejection fraction does not improve, we go ahead and plan the ICD. Now, indications for cardiac resynchronization, CR. Basically, anyone who needs an ICD or a pacemaker, we always think, do they need an extra lead for resynchronization or not? So any indications for pacemaker or ICD, we always think if there is a need for resynchronization. The decision is primarily driven by 3 factors, or actually 4. The ejection fraction, the QRS duration, heart failure symptoms, and the percentage of pacing that is anticipated. And this table summarizes them. So if the strongest indication is the first column, which is an ejection fraction of 35% or less, and the strongest indication is the first row, and the QRS duration is more than 150 milliseconds, and it is of left bundle branch block morphology. New York Heart Association 2, 3, or 4, that's the strongest indication. Then intermediate indication, it's also considered class 1, EF less than 35%, QRS duration less than 150 but more than 130, and it is of left bundle branch block and 2 or 3 New York Heart Association. Now, if there's non-left bundle branch block morphology with an EF of 35% or less, the guidelines now allow us to implant a CRT if the QRS duration is more than 150. So if it's a right bundle, the QRS duration has to be more than 150, or sometimes non-specific intraventricular conduction delay. So in summary, CRT in its default biventricular pacing was primarily introduced to correct pre-existing intraventricular conduction delays in patients with severe LV dysfunction, thereby improving their ventricular function. So, and then to counteract the effects of left bundle branch block and restore a more physiological activation. Current guidelines also indicate that CRT will be useful for people who are symptomatic heart failure and ejection fraction less than 50%, who require frequent ventricular pacing more than 40% after device implant, in the absence of left bundle branch block. In other words, if someone, the blockage F trial told us, if someone comes with a heart block and needs a pacemaker. And their ejection fraction is less than 50%, and we anticipate frequent pacing. In other words, more than 40%, then we should go ahead and do a CRT pacemaker instead of a single lead artery pacemaker. Special scenarios for CRT indications, atrial fibrillation is one of them. Several trials showed that patients with recurrent CHF exacerbation that is due to AF with RVR, that we try to control with medications, with the applications, with antiarrhythmics, and we could not. Then the patient is labeled as long-standing persistent atrial fibrillation. Those studies showed that AV nodal ablation and BiV implant, CRT implant, actually improves survival and reduces hospitalizations and has a mortality benefit. The most famous trials are PAVE, PACE, AVAIL, or PACE, ABLATE, and PACE trial. So we see that frequently, and I think we are underdoing or under following these guidelines. So to summarize, CRT or cardiac resynchronization therapy, there are classic indications are those with an ejection fraction less than 35% and who are not and have well been on GDMT for 90 days or more without an improvement. Those with AV block, heart failure, and ejection fraction less than 50%, they get a CRT. Those with chronic AF with anticipated ventricular pacing, obviously if we do node ablation and an upgrade from a pacemaker to CRT is considered a CRT. So to conclude, I just summarized the indications for pacemaker implants, signs of dysfunction, AV block, alternating one branch block, and other specific or conditions. And the same thing for ICD. Primary prevention ICD does save lives, so we should always implant it. And secondary prevention if VTDF occurs more than 48 hours after MI, and the indications for pacing with pacemaker CRT, two main scenarios, anticipated pacing more than 40%, and those with ejection with atrial fibrillation causing recurrent heart failure exacerbations. This is a summary of like an algorithm that you can green is almost the most suitable one, ejection fraction less than 35%, GRS duration. If you look at the first one, and left bundle morphology, and more than 150 milliseconds, and then 2A would be less than GRS duration between 120 and 150, still left bundle pattern, or QRS of non-left bundle, but more than 150 milliseconds. So thank you for listening, and if there are any questions, we'll be
Thank you, Dr. Basil. Our next speaker, Dr. Munir Zaqqa, well-known senior electrophysiologist. He will be talking about supraventricular tachycardias. تفضل دكتور منير.
شكرا. مساء الخير. You know, we have a task force. We're trying to do protocols for management. It's really, in case of emergency, when there's a protocol, it makes management easier. And also, there are the name specifically protocols, not guidelines, because we take from guidelines, but we modify according to what we have in Jordan. For example, in guidelines in other countries, they might have medications or procedures we don't have. So when we say management or protocols for Jordans, we try to take what we have and put it as in the best way we can as a protocol or management. So that's why I use SVT management or protocol like TaskForce for guideline. So the term supraventricular tachycardia is a term used when the rate is above 100 for tachycardia and when the tissue and mechanism involved is above the bundle of hairs. Usually patients present with symptoms of palpitation, that's the most common symptom. But you'll be surprised sometimes they have no symptoms at all, or they might feel something wrong just without knowing anything, and when you do ECG you find the heart rate is fast, or they might present with syncope or dizziness. So there are varied symptoms which are usually related to the heart. So you have to think about it, and it's usually apparent on physical examination or an ECG. So let's start with the algorithm for the management of SVT. So the first thing when somebody comes with symptoms, you have to assess the patient. And really the main thing of assessment initially is to see if he's stable or unstable. And if he's unstable, of course, you have to work faster. If he's stable, you have more time for management. And also do the necessary things like vital signs, ECG, and lab in that case. So ECG, of course, we're talking electrophysiology is paramount importance. ECG is good, or at least if we have a rhythm strip or a monitor to help us in the diagnosis. So the first thing, if somebody comes with a tachycardia, with an ECG, we have to know, is it a problem with electricity like SVT or something else, or is it sinus? Because sinus, of course, it means everything can happen, including psychological, including simple things like sometimes hypothermia, mild infection, or it could be really life-threatening things like if somebody comes with tachycardia, you might think of pulmonary embolism or severe bleeding, so patient might be at very high risk of death if you don't have it. But the management has to be at the underlying cause if it's sinus. Now, if it's not sinus and SVT, so first, is the patient stable? If he's not stable, the first treatment is by indication cardioversion, because that way you restore sinus rhythm quickly. So usually give 50 to 100 joules, preferably synchronized, and that usually restores sinus quickly. And the good thing about defibrillator, they're available in most emergency rooms. I noticed, when we call 911 in Jordan, usually ambulance come very quickly and they're really efficient, but they usually don't have defibrillator, so maybe we should provide Very good. Okay, thank you for update. Okay, because it's life-saving in many cases. So if the patient is stable, so now we start with the algorithm for SVT management. So with SVT management, we have to look at the ECG. Is it regular or not regular? If it's not regular, actually it's a different protocol, and my colleague will be presenting it, the irregular SVT management. But if it is regular, and this is a good time to put an ECG for an SVT. So we see that the heart rate is fast. Usually in SVT is about 150, usually 170, 180 range, but can be up to above 200, 220 or 230. And it's very regular and narrow QRS. So if it's, now you have ECG and the patient is stable, the algorithm for management. The first step, if he's in the ER, try Basil maneuver. And usually Basil means you have to increase the vagal tone. There are many methods, and everybody according to his experience, and it might work or not. But it's simple to try, like carotid massage, or gag reflex, or pressing on the abdomen. That works in some of the patients. And in fact, you can teach it to the patient to do it himself in case before coming to the ER, because it's something simple to do, but it works sometimes and sometimes not. So if that works, that's good. So the algorithm will continue. If it doesn't work, then we continue further with the algorithm until we restore sinus. So the next step is adenosine. And it's good, and adenosine is available in Jordan. And it's simple, it's very short-acting medication, it lasts only seconds in the body, and that's why you have to give it in a bolus. You have large IV access, give up to 80 milligram adenosine, and almost in every patient that restores sinus rhythm. But with some people, the SVT might be insistent, so it might come back, or in few cases it might not respond. So then we have to go further in the algorithm. So if it comes back or if it doesn't respond, then we might give AV nodal blocking agents. And we do have some IV agents like IV metoprolol. We don't currently have IV calcium channel blocker, but we have choice over either IV beta blocker or calcium channel blockers to try to restore sinus rhythm. If the mechanism of the SVT is not related to the AV node, not reentrant, for example, atrial tachycardia, we might at least achieve rate control with that case. So if that works, that good. If it doesn't, then we might go to stronger medication. And generally that means in Jordan, IV amiodarone, or other antiarrhythmic might be IV digoxin. But when you start using antiarrhythmic medications, you have to be careful because those medications sometimes have unwanted side effects. So you have to be really careful in knowing how to use them. And even with IV beta blockers, there are certain contraindications you have to be careful. For example, if somebody have Wolff-Parkinson-White syndrome and AFib and fast rate, you have to be careful when using them. But with experience, they do make a difference in retaining sinus rhythm. And the last step, if we don't achieve in a stable patient, we might use cardioversion to restore sinus rhythm. This is for the short-term management. So the important with the long-term management is how to manage patient so that it doesn't happen again. So part of the management is education. So you have to discuss lifestyle modification like stress, alcohol, caffeine. In general, it's related to stress, but who's not under stress, so it's difficult to manage. But at least you can tell them to relax and see what you can do in that regard. And sometimes knowing awareness of triggering factor might help the patient in avoiding them. And you have to follow up them regularly and to monitor their rhythm and adherence to medication. And adherence to, and also to watch for any side effects of the medication. So the medication we have for the long-term managements are beta blocker as a first line, like metoprolol or bisoprolol, or we might use calcium channel blocker like diltiazem or verapamil. Antiarrhythmic medication might be used, but only in specific indications. And as a last or as a first resort, we might go to electrophysiology. The nice thing about electrophysiology, it's a cure for the condition. So you might offer it to the patient, or you might offer them to try the medication and see how they respond to the medication. But always keep in mind, if they don't respond to medication or if they have side effect of medication, then offer them the AP study because it's curative and it's a low-risk procedure and it really helps the patient from something that can really be troublesome to them. Thank you.
Thank you, Dr. Munir. We'll leave the discussion till the end. We have Dr. Ayman Hammoudeh, Senior Cardiologist, Istishari Hospital. He will be talking about conducting cardiovascular registries in Jordan, the Jordan AFib study as a prototype. Tafadhal, Dr. Ayman.
Thank you so much. So I was asked by the EP group to talk about our experience in the Jordan Atrial Fibrillation Registry, which was one of our group suggested that was very successful. Hopefully, they want to duplicate that, so we are going to go through the procedure of doing this registry in general and specifically the Jordan Atrial Fibrillation Registry. Can I have the first slide, please? So I'll be talking about registers in general, how important are they, and what are the components of a successful registry. And then I will talk specifically about how we managed to do the Jordan Atrial Fibrillation Registry, which was done during the COVID. And you'll see how difficult was that, despite that, but a very successful and productive product for Jordan as a whole. Okay. I can't move. Okay. So the importance of medical research, يعني بعض الناس ما لهمش دخل بالresearch. Why to do research? For others are very important. 3 reasons. Number one, we are dealing with the number 1 killer globally, regionally, and in Jordan, which is the cardiovascular disease. Number 2, research is the key word to improve health. And number 3, research is the key word to show the scientific level of every country. So there are 3 facts that are important to consider when looking at the medical research in Jordan. The first fact, look at the population pyramid in Jordan 5 years ago, 2020, and in 30 years, 2050. You will see that the population, the aging population will be more evident, so we will have more grown-ups, and with this, we will have more cardiovascular disease, especially atrial fibrillation, because we know AFib is a disease of the elderly. And at the same time, look at fact 2. Look at the inverted pyramid of cardiovascular disease. You can see up top is the elderly men and women, where there is a lot of cardiovascular disease, and as ages go down and down, you see less cardiovascular disease. The third fact is that cardiovascular disease is the commonest cause of death as we sit in Jordan, and these are data from the Ministry of Health, STEPS 2019 and the WHO 2022. We know that the prevalence of cardiovascular risk factors in the adults in Jordan, you can easily say hypertension 1 in 5, diabetes 1 in 5, and cholesterol 1 in 5. And then we know that the non-communicable disease are responsible for almost 80%. Of every 10 deaths in Jordan, 8 are due to non-communicable disease, and half of them, 42%, are due to cardiovascular disease. And at the bottom is the age-adjusted mortality is 99 per 100,000 population, which put us at number 111 in the world. So we are in the middle. On another front, the clinical trials is a site that registers all the studies, and it is mandated for anyone before publishing to register in this site. This is one of the sites. This is the FDA site affiliated with the US National Library of Medicine. So look at the escalating number from the year 2000 to the year 2020, where the number is really very, very high. So this is the map just a few weeks ago. They give every day, every week, they update the map. And you look at the Middle East at the center, we have around 21,000 studies reported. Comparing to other areas, maybe we are better than Africa or South America, but look at the United States, Canada, Europe, and China on the other side. To your far right is the Middle East. So you can see we are not that bad. So we have 300 something, better than most of the Arab countries in our region. And thanks to all of you who are involved, whether you are cardiologists, students, etc. And a good number of these studies are cardiovascular, actually. And our group, which is the Cardiovascular Academy, previously known as JCC, Jordan Collaborating Cardiology Group, we did everything on this pyramid. We have randomized clinical trials, we had double-blinded, many trials, but most of our work was with registries. So registry is a system that uses observational method to collect uniform data to evaluate specific outcome for population defined by particular disease. In your example is atrial fibrillation, so that we can build up knowledge and guidelines and improve the survival. We know that local data and registers have limitation. Okay, these are non-randomized. We have unmeasured factors that we cannot control. We have some missing data. We cannot generalize it. However, to your left in green, we have strengths because it is an actual practice of the patient, of the population, unselected population, diverse populations, and broader use of outcomes. So these are the 3 waves of our group's studies from the year 2000 up till these days. You can see we have so many studies. Most of them, all of them were registered, and all of them were published, and now some of them are in actually international meta-analysis, as you will see. So how to build up a clinical registry? 4 steps. You need to collect data, we'll talk about that. You need to manage the data and interpret the data, and then you have to analyze it and report it. You cannot have a data finjan, زوبعة في finjan. You just do it among ourselves and no one knows about it. It has to go global. So step 4 is to generate world evidence and dissipate your knowledge so that everyone knows that Jordan is doing something in the field of medicine. So to set up another registry for atrial fibrillation, define the purpose and objectives. In our case, to know the definition of the presence of atrial fibrillation and the patients who have atrial fibrillation. A plan to register it, clinicaltrials.gov. You have to set up an account there and start registering. You have to get an IRB approval. Identify the target population, adults with AFib. We're not looking at pediatric AFib. Determine the data elements, what data you want to collect, clinical profiles and outcome. Develop a CRF, which is case report form. Ensure data quality. You have someone who always looks at the data and asks the investigators to change it or to modify it. And then you have to have a good statistician. And finally, you have to get your work noticeable. You have to show it in conferences. You have to show it in manuscripts and media. However, 3 things to remember. Number 1, you need a good PI, primary investigator, and the steering committee. You need someone to work. You cannot depend on others to work. It will fail definitely. You need sites, investigators, and site teams. Number 2, which is very, very important. You cannot have a one-man show, one who shows everything. Every conference, the same guy presents everything. You have to delegate. You have students to present. You have co-workers. You have colleagues to present. And then you have to find funding if you need funding. The Jordan Atrial Fibrillation Study with 2020 مريض, 30 manuscripts, 30 presentations all over the continents. الموازنة كانت كم دينار؟ 0. Okay, so types of data collection. The primary is the patient himself, and secondary is you get health records and files. Types of data entry depends on your resources. You have money, you can have computers, you can have internet. In our case, it was all paperwork. Type of data analysis, three levels. Descriptive, we look at who are the patients with atrial fibrillation, gender, risk factors, إلى آخره. Draw conclusions, and finally, which is important, is to predict future outcomes, as you will see. Every point here, it will be adapted to the Jordan atrial fibrillation. So again, in the middle of the slide, you see JOFib, which was done between 2019 and 21. We had 22,000 patients. All right. So we had a lot of registries in atrial fibrillation in the region. However, most of them, they were large, but unfortunately, they come from the Gulf with heterogeneous groups. And in the Gulf, they put citizens and expatriates. So Southeast Asians are big working force in the Gulf, and really they don't show the profiles of Arabs. That's why this is a main disadvantage of the Gulf registries. The studies did not evaluate the prevalence and disparities between valvular atrial fibrillation and non-valvular. No study did that. And many of these were conducted before the widespread of DOACs. So you open your Google, and most of the time, warfarin is dominating the whole picture. And finally, the sample size sometimes was small with retrospective design, and no data looked at the adherence to applying medication in high CHA2DS2-VASI score. All right, so our patient, this is number 1 rule, define your methodology. So all consecutive patients, you cannot select good patients, and anyone who dies in the hospital, you don't enroll him. You have to enroll every patient, adults, informed consent, and then you get your data collection. You have all the data there, and then at the end of the follow-up, we had 1-year follow-up of every patient. So these are the centers. You have to gather your team. Our team was 112 individuals, 29 participating hospitals and clinics in 5 cities, 4 university hospitals, 1 public hospital, 1 cancer center, 3 private teaching hospitals, 9 private non-teaching hospitals, and 11 outpatient clinics. Then you have to define your time work and timeline. So you had to plan study launch, we used the Independence Day, May 25, to launch it so that everyone remembers the day. And then the projected enrollment was in 1 year, May 25, 2020. And then we had 1 year follow-up. Actually, we were stuck with the COVID-19, so we were delayed 5 months. However, we managed to follow all the patients for 1 year. Okay. And then we started presentation because we said you have to show your knowledge to the world. You have to show your data. You cannot just do it locally. So these are all the conferences 2020, 2021. We showed just the baseline phase of the patients. Who are our patients that we'll see. And then after 1 year of follow-up, we showed the conferences, ACC, ESC, etc., the data of outcome. Everyone is interested. Of every 100 Jordanians with AFib, how many ones will die at 1 year? What is the rate of stroke? No one knows. What is the rate of bleeding, right? So this is what we aimed at. And these are the publications. And then we were finally ended up in meta-analysis with atrial fibrillation studies. They looked at meta-analysis in the world. They contacted us for AFib in women, AFib with CAD, AFib in diabetes, AFib with thyroid. I think that was Dr. Hanna's paper. So we shared with everyone a lot of authors to write these papers, and one of them actually was included in this international meta-analysis. So what are the results? So inpatients were around 28%. Most of the patients were outpatients. Female to male, 50%. And this is the age group. And you look at these, this is what's going on. So above the age of 51, you have almost 90% of the cases, which goes with the world literature. And then this is, again, a very striking fact. The commonest 5 risk factors, as you see, but the most common 2 are hypertension and obesity. And this is common in all over the world. So there are things that we agreed with the world literature, others were different. And of every 100 AFib in Jordan patients, every 109 had valvular AFib, which is the metallic valve, and as you know, rheumatic mitral stenosis. So these are the types of atrial fibrillation. And this is a very important slide. The CHADS, at that time we had CHADS-VAS score. As you know now it is CHADS-VA without the 6th category. So as you can see, in men, 79% had high CHADS-VAS score, and in women even higher, 84%. That's why our patients have risk factors in AFib. That's why they score high in the CHADS-VAS score. How often did we use the DOACs? Of those who had high score, 86% had DOACs, and 14% did not have it, although they were eligible. The reasons vary. Sometimes they were enrolled for sepsis infection, they cannot use anything. Some were enrolled for infection, for preoperative evaluation. We looked at those with heart failure atrial fibrillation, which is 24% of our patients. And we saw that these patients had the worst prognosis of all. This is what everyone has to cite. What is the rate of down there stroke and systemic embolization? 4.5% at 1 year. What is the rate of major bleeding? 49 patients, which is 2.6%. And everyone is scared of intracranial hemorrhage, 0.5%. We had 9 cases. In 2020, 9 cases had intracranial hemorrhage. The far right is the clinically significant minor bleed is 7%. So we can easily quote a stroke 4.5%, bleeding 2.6%. All right, 2 more slides. What are the factors that predict stroke, systemic embolization in our population? Hypertension, double. Enrolled as outpatient, triple. Chronic kidney disease, double. 6 times when you have high CHADS-VAS score, and 3.4 past history of stroke. More important, what predicts death in AFib patient in Jordan? Diabetes, elderly, inpatient, coronary heart disease, heart failure, and major bleeding. All right, what protects them against death? 2 things. Being not obese, BMI low, and use of oral anticoagulant. So in conclusion, clinical research is not a leisure time activity. It's an important, serious, fruitful work. Clinical registries' success is built on good planning, well-gathered team, avoid a one-man show project, aim high for international presence and presentation. You have to go global. The Cardiovascular Academy's JOFIB study has fulfilled its objectives. More than 30 manuscripts, more than 30 presentations in every international congress. And the AP group now, the plan is greatly welcome to do the second Jordan AFib registry. This needs perseverance. It needs a great chance to see differences between the two registries. Thank you so much.
Thank you, Dr. Ayman. We have Farah Qtaishat. She is the head of nursing education at the specialty hospital. Farah is also an AHA TCF instructor for basic and advanced cardiovascular life support. Dr. Farah will be talking to us about centers of excellence in nursing, lifting the quality of care. تفضلي فرح.
Good afternoon. It's an honor to be here today to talk about centers of excellence. It's a concept that changed the way of delivery of healthcare, high-quality healthcare, and specialized care for patients. In the modern healthcare landscape, the demand for excellence, safety, and high-quality patient care continue to grow up. And the best model for achieving these goals is through centers of excellence. Actually, centers of excellence, it's not only a specialized department. No, it's the best model for achieving exceptional patient outcome, and this can happen only through collaboration among different healthcare professionals. Nurses only cannot achieve this. If you want to define centers of excellence more clearly, they are even specialized institutions, or we can say it's a specialized unit within healthcare organization that is focused on innovation, best practice, and continuous quality improvement in specific areas of patient care. Actually, there is 5 key objectives of centers of excellence for nurses. First of all, they promote clinical excellence and evidence-based nursing practice. They provide advanced, and this could not be achieved actually without advanced nursing education, and for sustainability, continuous training and education. Strengthen leadership and policy development in nursing, supporting innovation and research, and for sure this will enhance the patient outcome and the quality of healthcare delivery. Let's discuss quickly the key roles and functions of centers of excellence. Actually, the basic is to develop education and to ensure the continuous and advanced and specialized nursing training. This is specific nursing education and advanced training. It will provide or help the nurses to provide advanced nursing care. Nurses will be able to deliver specialized and complex services to meet these special patient needs. Also support research and innovation. This will help to develop care protocols, clinical pathway, and the guidelines. Fostering interdisciplinary collaboration, as we mentioned before. Nurses alone cannot do everything. We need holistic patient care through nurses, nutritionists, physicians, pharmacists, advanced psychiatric nurse specialists, social worker to support the family, and cardiac rehabilitation team. Also, it will support policy development. Why we need high-quality nursing care? Actually, we need high-quality nursing care to improve the patient outcome, reduce hospital readmission, and this will lead to greater patient satisfaction. And this could be achieved through structured centers of excellence. This will strengthen the nurse profession and help to achieve better healthcare quality. Let me please introduce a successful model for best practice. My hospital, the specialty hospital, it was the first hospital in Jordan who received joint commission certification, JCI certification for disease specific, especially for heart failure and myocardial infarction. And actually, this reflects the commitment of a specialty hospital to deliver high quality and evidence-based cardiac care aligned with international best practices. Actually, I was working as ICCU nurse in that period of time. I underwent the full process with the hospital. First of all, we start to train nurses on international clinical guidelines. It took several months. Then we go for the competency to ensure that our nurses are competent. They have enough skills and knowledge to deliver this specialized nursing services for these patients. Then we go for the special care pathway. We talk a full orientation regarding the guidelines that is adopted by the specialty hospital, the clinical pathway that, again, it's teamwork. It's between nurses, physicians, nutritionists, as we mentioned, a holistic patient care. And finally, the nurses take a job title under cardiac nurses. So this was our successful experience at the specialty hospital. All nurses and midwives in Jordan, they are under the umbrella of Jordanian Nursing Council, or the JNC. JNC is the regulatory body responsible for organizing and developing nursing, registered nurses mainly, and midwife profession in Jordan. There is regulation number 85 in 2016 under the name of a professional classification and specialization. Actually, this regulation establishing the criteria for both specialist and advanced specialist nurses. Actually, at specialty hospital, we support specialist and advanced specialist nurses. We have, for example, oncology nurse specialist. He's the one responsible to deliver specific training or specialized training regarding safe chemotherapy handling and administration for nurses. He's also the one responsible to ensure they are competent. Also, we have pediatric advanced nurse. We have psychiatric nurse specialist. Through all the hospital, there is referral criteria, so our nurses know how to assist patients and how to refer to this nurse. So we highly support the specialist and advanced specialist nurse. The JNC has a lot of effort to define the specialist and advanced specialist criteria. This effort arose, mainly in 2025. On May 2025, the JNC held the specialization exam for across the ST nursing subspecialty. And then in September 2025 and until today, there is a lot of discussions through a committee developed through the JNC. This committee discussed the scope of a practice for both specialist and advanced specialist nurses, okay? This discussion mainly focused on the legal and operational framework of specialist and advanced specialist nurse. Actually, despite the progress that we have, but we still have gap on legislation regarding the roles, responsibility, and especially the clinical authority for specialist and advanced specialist nurse. As we mentioned, the progress, or let's make a summary progress for the JNC work on specialization and advanced specialization. As we mentioned before, we have the specialization and the classification regulation. In the specialized field, the JNC held exams for specialization under 16 nursing subspecialty regarding professional recognition and the classification. The JNC issues license for specialist and advanced specialist nurses, and as we mentioned, we still have gap in legislation regarding the clinical authority and responsibilities and the legal framework for specialist and advanced specialist nurse. Why we need to have a specialized cardiac nurse? The specialized cardiac nurse, it can bridge the gap between the routine nursing care and the advanced and specialized care for these patients. We cannot forget the collaboration between the healthcare professionals, especially the physician and the nurse. This collaboration through the patient journey, it will support the patient from acute intervention to rehabilitation and until the secondary prevention. Specialized cardiac nurse have many roles, such as monitoring complex cardiac patients, interpreting diagnostic results, administrating specialized treatment, and providing patient education on lifestyle modification and medication adherence. And this could not be happen without training and continuous education and competency for sure to have the enough skills and knowledge. This has an impact on patient for sure. This will lower the mortality rate, ensure better continuity of care, especially if there is collaboration, fewer medical errors, reduce the hospital length of stay, higher patient satisfaction rate, and development of better care. We still have challenges. Yes, we have challenges. First of all, limited funding and resource for centers of excellence. Workforce shortage for Saudi, the returning of nursing with this high workload and burnout or migration is difficult. Lack of policy support, as we mentioned, some gaps in the rules and regulation regarding the clinical authority of nurses, specialists, and advanced specialists. Insufficient research integration, translating research into clinical practice still have some challenges and resistance. And finally, resistant to change. Any new concept still have resistance. For future directions, we recommend and hopefully strengthen policy and institutional support to promote academic partnership between hospital, universities, academic people, and research centers to strengthen the nursing education, encourage research and knowledge sharing, building network between centers of excellence for knowledge sharing. Hopefully this happens. Adopt continuous evaluation. Always and regularly we have to assess the outcome, the impact, and effectiveness. And thank you.
Thank you very much, Rana. Thank you very much for being with us through this session. We have a few questions to our speakers. If I may start with a question to Dr. Basil. If you remember, Dr. Basil had talked about pacemakers, ICDs, and CRT. So the question to you, Dr. Basil, let's say you have somebody who presented with a complete heart block, and the plan is to put a pacemaker. But to your surprise, the echo ejection fraction came out to be low, 35%. Would you at that time put an ICD? And if I may take it further, let's say there was left bundle, would you put a CRTD for such a patient who came just for complete heart block, or just a regular pacemaker? Thank you.
So assuming there are no reversible causes, normal coronaries, if someone needs a pacemaker and was found to have low ejection fraction like this, a new adjustment or addition to the guidelines say you can proceed actually with an ICD right away. And if he has a right bundle branch block, CRTD would be the answer. Because we don't want to put a pacemaker today, put him on GDMT, and then do another echo in 3 months and find out that we need to upgrade. That's a big risk of infection.
Well, that's important. Thank you very much, Dr. Basil. Dr. Munir, let's say you have a young lady or a young man who comes in with a supraventricular tachycardia. You gave that patient adenosine in the emergency room, reverted, put them on a beta blocker, recurred on a beta blocker like 3 months after. At that time, would you consider ablation or switching from one beta blocker to another? What would be your approach?
The guidelines in USA say go for ablation right away, but I think Jordan society is different, because when you offer ablation, you have to explain the risk, which is heart block and need for pacemaker. So in general, I tell them try the medication. If you're comfortable with the medication, that's good. If it comes back, we'll try make some minor changes. So I think 3 months is still early. But if it comes back recurrent more than 2 times per year, or if you're not comfortable with the medication, even psychological, some people don't like to take medication, then I would offer them the ablation.
Okay, thank you. Dr. Ayman, what do you think about the registries in regard to the public health care sector, Royal Services role in the JOFIB study? لو دكتور هادي هون كان سألنا عن heart failure registry, if there were contributions from the Royal Services the Ministry of Health hospitals. What was their contribution, and what is your future plans for them? Thank you.
Thank you, Dr. Hanna. We did a few registries. We did the PCI registry, we did the atrial fibrillation registry, we did the triggers in MI registry, and one more. So in all of them, we had all the sectors involved except the Royal Medical Services. So we always deal with hospitals, public. We depend on Al-Bashir and the Mustashfa Al-Amir Hamza in Amman and Mustashfa Al-Amira Basma fi Irbid. So we always have teams with us. We get their IRB approval, and then we work with them. About 1/3 of the cases in our studies come from public hospitals, 1/3 come from private hospitals, and 1/3 come from universities. And in the atrial fibrillation study also, we got a special population, which is the cancer from King Hussein Cancer Center, which really contributed good cases because AFib in cancer is very important. So we always try to involve all the sectors in our registries.
Thank you, Dr. Ayman. One last question, Sister Farah. Going back to registries, what do you think the proper setup to find, how would it be different in the Center of Excellence in regards to registries? How would you promote such registries at your center, and how do you see that different from other institutions? How would you enroll your patients differently than others?
Okay, thank you, Doctor. First of all, nurses play a vital role in patient registries. One of the key role function of nurses is to make data collection, data entry for the patient, and ensure the accuracy of patient data. And as Dr. Ayman mentioned before, the collaboration between nurses and physician in registries issue can ensure that we have a rich and full data that we can use later on in the researches and innovations.
Thank you very much. Audience, please, if there are any questions, go ahead. We have Dr. Mohammed, we have Dr. Ammar. Do we have the mic, please?
So hello, it's a clinical scenario question. We have the problem with patients presented with heart block, type 2, and Dr. Basil told us in type 2B heart blocks, we have to immediately put a pacemaker. That's a direct consideration. In patients with 2-to-1 conduction, I find it's difficult to differentiate between type 2A and type 2B. What to do with these patients? If they have 3-to-1 conduction or 4-to-1, that's easy to tell. That's Winkelbach or Mobitz. But those with one is conducted and the other beat is not conducted, what to do with these patients?
That's actually a very good question, and there are clues or signs about the level of block. So if the level of block is at the AV node, this is most likely benign. If it's below the AV node, it is not benign. Signs of AV node block is PR prolongation. So if the PR is long, that's a sign that the block is at the AV node. We're talking only 2-to-1. If the QRS is wide, that's a sign that the block is below the AV node. So those are some clues about it. Now, the other differentiation, you can put them on a treadmill and make them exert themselves. If the conduction gets better, this is at the AV node. If it gets worse, this is infranodal and they need a pacemaker. And I always consider cardiac monitoring.
Dr. Ammar.
My question to Dr. Ayman, I want to ask about the percentage of patients in JOFib who were fully anticoagulated and well treated.
We looked at those who were eligible for the anticoagulation, which is the CHADS VAS score 2 to 3, men and women, okay? The percentage was 8 to 9 out of 10, so it was a great percentage, 86%. Of those, this is year 2019, 2/3 were in DOACs and 1/3 was on warfarin. Not bad either, because literature in the other areas in the region, mostly warfarin. I'm sure the new study, I'm sure the percentage will increase in those who are eligible, maybe more than 95%. And I'm sure the percentage of DOACs chunk will be more than warfarin. But overall, these are excellent numbers reflected by low numbers of bleeding and low percentage of bleeding and low percentages of stroke and systemic embolization.
Any more questions? Dr. Abdali.
My question for Dr. Munir. In fact, in children, the SVT is quite different, the course and the onset. What do you think the triggers for SVT in children? Why did it start at the age of 0? Why did it start at the age of 5 years, 10 years? And we have different onset and different ages.
Yes, here we're talking about the mechanism of SVT.
Mike, Dr.
Yes, here we're talking about the mechanism of SVT. So yes, of course, in children it's different. And also when we treat, it's different because of their size and fine structures. But usually, like, there are things that come with birth, like Wolff-Parkinson-White syndrome. But why tachycardia starts at a certain age, it's not known exactly. But also, so SVT are three things, either AV nodal reentrant or WPW or atrial tachycardia. So the atrial tachycardia also is more common in children and it might disappear by itself. So really you have to know the mechanism and then treat accordingly.
So in other way, no atrial tachycardia, not all atrial tachycardias or SVTs, they do need ablation, right or not?
In children, of course not. Sometimes if it's ATAC, it might disappear. And even if it's WPW and with minimal symptoms, you might wait until he's older and it's easier to ablate or refer to a specialist center if he has symptoms.
Okay, thank you.
Okay, thank you everybody. We have one more lecture for this session. It was supposed to be Dr. Ra'ed Al-Awaisha, but he is late, so we're going to go ahead with Dr. Layth Saleh. He is an electrophysiologist at Al-Istishari Hospital. We welcome Dr. Layth. He will be talking about wide complex tachycardia. أهلا وسهلا دكتور ليث، تفضل.
Thank you, Dr. Hanna. يعطيكم العافية. So a quick word قبل ما نبلش. This talk was again echoing Dr. Munir's comments before. We did decide to actually come up with some guidance for some common and important problems to deal with, especially in the emergent or urgent situation, like in the emergency room, or if you're a resident or physician on call in the hospital to deal with these problems. And we will be talking in this talk about regular wide complex tachycardias and why this is an important condition to discuss. First of all, for disclosures, I really don't have anything to disclose. And the second disclosure that I have is this really is not an EP talk. And it is, of course, geared like every other talk that we actually had today towards the general practitioner or the emergency physician. And that's why even medical students, medical residents should really be aware of this sort of workflow because it helps them a lot in making a decision in a very sort of time-sensitive diagnosis and time. I'm going to start with the main source for us in talking about this topic today. This is the 2015 American Heart Association algorithm for adults with tachycardia with a pulse, meaning we're not in the ACLS or the CPR cardiac arrest arm. This is the adult tachycardia management. And they do exist. The guidelines exist in the adult tachycardia. There is something that does not really exist, which is really in one box here, box 6. This is basically the regular wide complex tachycardia. Actually, this is the regular tachycardia, and then we're going to talk about the details as we actually go forward. This is just like a quick overview of what we're going to be discussing today. So basically, these are the tachycardias that we are going to be discussing today. As you can see, there are 2 tachycardias with narrow complexes and 2 with wide complexes. There are 2 that are regular and 2 that are not regular. فبنحكي احنا اساسا بدنا نركز على الاسئله كما بنسالها بهذا الكونتكست. Is this regular or irregular tachycardia? إذا كانت irregular tachycardia, they have their own algorithm. We're going to leave it and focus on regular tachycardias. Second question is this a wide or narrow complex? And we are focusing on wide complex tachycardia and the management of that tachycardia. Before we actually dig deeper in regular wide complex tachycardia, I want to add 2 things. Number one, this is not or should not be sinus tachycardia. Like Dr. Munir discussed, sinus tachycardia is a secondary problem. You have to always aim to treat the underlying condition, and it can come with a wide complex. Secondly, every tachycardia that we will be discussing in this talk has monomorphic morphology, meaning, like you see this tachycardia, it has the same QRS complex in all these beats. So with this in mind, I want to draw your attention to something that I don't want to discuss today in detail, but this should be imprinted in your brain as a cardiologist and even as a physician, internal medicine physician or emergency physician. These are 2 tachycardias. They're wide, they're not regular, and they're not monomorphic. You can see the first one is polymorphic with different QRS complexes. They're wide for the most part. There are some narrow in the beginning and the end. And the second one is also wide with different morphology in the morphologies in the tachycardia. And these are both irregular, so they're not really part of our talk today, but I really want to emphasize these are important things to keep in the back of your mind when you actually are managing tachycardias. These tachycardias are well, first of all, the tachycardias are irregular, wide QRS complex with a varying QRS morphology. So the morphology does not stay the same along the tachycardia. So number one, prepare to shock these patients. And number 2, make sure that you call an expert. A cardiologist or an electrophysiologist would be a great addition to actually guide therapy with these patients. Why? Because they're both very, very dangerous rhythms. The first one is polymorphic VT in the setting of long QT, so this is Torsade, and it has to be managed very well and very carefully. And the second was the atrial fibrillation with WPW, and this also is a very important entity to recognize and treat well and not make things worse when you actually treat. Back to our problem. Why do we want an algorithm? There are 2 things that are actually important in the management of wide complex tachycardias. Number 1, some of them are unstable and need urgent management. And number 2, you want to get as many or as much information as you can. So if you just treat it, if you treat everyone with cardioversion, you will end the problem temporarily, so you will actually lose important diagnostic data. And sometimes you actually cannot just treat patients with cardioversion because of specific circumstances that we will actually discuss in a little bit. So these are 2 tachycardias. They're both wide, complex regular tachycardias. And as you can see, it is difficult to actually recognize if this is a VT or an SVT with aberrancy. And I would actually argue that this is even difficult for the electrophysiologist without knowing how to actually go about these tachycardias and go along the steps that you actually should go for diagnosis and treatment. So with that in mind, there are clinical challenges, like we said, when you deal with a wide complex tachycardia. Number 1, it's difficult to diagnose the arrhythmia between VT and SVT with aberrancy. Number 2, there is often the need for urgent treatment, and these tachycardias are not always stable. And number 3, it's complex to actually deal with this without an algorithm for someone who does not really have a proper training, and these are not very many. We don't have really enough cardiologists to deal with every emergency department to be there within minutes to deal with this, and we certainly don't have enough APs to do that. So a simple protocol with focus on rapid and safe delivery of therapy while getting as much information as possible becomes very important. In general, hemodynamic stability is going to be a very important determining factor, again, like we discussed with Dr. Munir in his talk. So hemodynamic stability has to be assessed right away. This is really the job of the provider that's seeing the patient. So the provider really has to get quickly a brief history to know exactly what's going on and why the patient is presenting, and assess the hemodynamic stability of that patient. And then there is a team that should be with the provider, the nurses, the techs, the CNAs, whoever is available, that should be basically doing the basic management relating to oxygen supply, basically oxygen mask, ECG, or getting the equipment for ECG and cardiac monitor, IV access, fluids if necessary, preparing for what could be needed for this patient. And then chronic management will follow later. So in the unstable patients, what is the unstable patient? I think everyone knows unstable patient means the blood pressure is low, or there is signs of end organ hyperperfusion. This could be altered mental status, chest pain, shortness of breath, cold extremities. An unstable patient will really show. And then the stable patient is clearly someone who is walking and talking, maybe has some palpitations, maybe has some dizziness, but then they sit down and they feel good. But basically we're talking about an unstable patient, someone with hypertension or signs of hyperperfusion. Of course, they need to have a pulse, because if they don't have a pulse, hopefully the physician will know to actually proceed to the cardiac arrest algorithm. So a quick word about cardioversion in responsive and unstable patients. Number one, cardioversion you can actually use energy between 50 joules and 200 joules for biphasic, and could go up to 360 joules also in some of the defibrillators. The more organized the rhythm, the less the energy that you need. I would say anyone that needs synchronized cardioversion for a wide complex tachycardia should probably be cardioverted between 100 and 200 joules. And you should always synchronize if you can. And this, I would even go and say that for even very unstable patients, if you can synchronize, it's always better to synchronize so that you don't shock in a vulnerable phase of the QRS complex, or the QRST complex, basically the ventricular depolarization and repolarization phases, so that you don't make a somewhat stable VT into a ugly looking ventricular fibrillation that may be more difficult to treat. So synchronize when possible, use appropriate energy. Don't be afraid to use high energy, but always also use analgesics and sedatives if you can, if it's feasible, and it does not delay treatment in an unstable patient. The diagnostic approach really is hemodynamic assessment, first of all, like we said, and then 12-lead ECG can give us a lot of information. Even if you don't diagnose it today, you can always just show it to someone who can show you real important diagnostic points to actually differentiate between the two, between VT and SVT with aberrancy. And then we go to the first, so we assume that we have a patient now with a wide complex tachycardia that is stable with good blood pressure and no signs of end organ damage or hyperperfusion. These patients, I think, are the patients that we're talking about today. The first thing that we actually want to do is attempt vagal maneuvers if it seems safe to do that. And vagal maneuvers include basically a bunch of different maneuvers that we will discuss right now, and then pharmacologic trials if the vagal maneuvers don't really give us the answer that we're looking for. When we do vagal maneuvers or adenosine or pharmacologic trials, and I've heard this from many physicians also with EP as well as cardiology, please record what you're doing, because what you may not see, someone else might actually see and get valuable information from. So either a 12-lead ECG, continuous 12-lead ECG recording, or a monitor would be great. Even if you can't have that 100%, حتى إذا ما في capability to record the ECG or the monitor on your phone, on the monitor, if the monitor cannot actually record these or print them out on your phone, أضعف الإيمان. We need some documentation of what happened with vagal maneuvers and pharmacologic treatment. So the purpose of the vagal maneuver, basically, the vagal maneuver is whatever it is, and we're going to discuss the different types in a little bit. But vagal maneuvers or vagal stimulation will cause basically a bunch of reactions or responses in the heart. Most importantly, slows down the sinus node rate, and even more importantly in this particular case, it blocks or slows down the AV node conduction. And why is that important? Because in SVTs, which is a major differential diagnosis in wide complex tachycardia, in SVTs, most SVTs are AV node dependent. So if you actually do vagal maneuvers and the SVT terminates, that means that the AV node was in fact involved, and that gives us important information. So in case of a supraventricular tachycardia, these are usually AV node re-entry tachycardia. Just a quick reminder, this actually involves, the circuit involves in AV node re-entry, the slow and fast pathway in the AV node, and nothing else. So nothing else is involved. So if you actually block, even temporary block the AV node, you will terminate the tachycardia, even if it's, you know, transient, but you will actually have a transient block or termination of the tachycardia. And the other option would be AVRT, which is pathway, and the pathway will be part of the tachycardia, but also the atrium, the ventricle, and the AV node. So it will go typically from the atrium to the AV node, to the ventricle, to the pathway, and then the cycle continues. So blocking any part of this will terminate the tachycardia transiently. So the AV node block will also do that. This is an example of wide complex tachycardia with vagal maneuvers. As you can see, the wide complex tachycardia actually terminates transiently, and then there is another sort of conducted beat, maybe with aberrancy again, and then there's a beat that's conducted with normal QRS complex. So this probably is a patient either with AVNRT or antidromic AVRT, which means that they use the pathway. To me, it doesn't look pretty excited, but this is not the discussion. This is just to show you that a vagal maneuver can stop SVT with aberrancy or SVT with a wide complex, and this is an example. What else can it do? If there is actually underlying atrial arrhythmia that is not dependent on the AV node, like atrial flutter or atrial fibrillation, vagal maneuvers sometimes can actually block the AV conduction, and you can see the underlying the underlying atrial rhythm. This is a good example. This was a very wide complex tachycardia. It looks scary. This is the example that I actually showed in the beginning of the lecture. And as you can see with vagal maneuvers, there is block, slowing down first of all, and then at the end of the rhythm strip, you can see in the upper lead, there is the sawtooth appearance, which is characteristic of atrial flutter with the same rate as the tachycardia that we were looking at. And then lastly, of course, limited effect on ventricular tachycardia, because ventricular tachycardia is really not dependent on the AV node, and it does not really have anything to do with it. So it's not really dependent on it as a mechanism, and it doesn't really depend on it to conduct from an atrial rhythm to the ventricle. So in the case of ventricular tachycardia, we actually can see that vagal maneuvers have no effect whatsoever on the tachycardia. And this is most tachycardias. Adenosine, very similar effect to vagal maneuvers. It actually does slow down the sinus node, but more importantly, in this case, it actually blocks the AV node temporarily. So it can terminate the SVTs that are AV node dependent. It also has some effects on some triggered ventricular tachycardias. I just mentioned this to be complete with the talk, but RVO-TVTs, for example, are responsive sometimes to adenosine, as well as some ATs that are adenosine sensitive. So it's not 100% that if you terminate, then it means that it's not AT or VT. It can be, but it is really unlikely. And to be honest, this is also why we want to see these rhythm strips when you actually use adenosine or vagal maneuvers. Of course, whenever you use adenosine can cause temporary decompensation, so always be ready to resuscitate patients. Usually the effect is very short-lived anyway, for 10, 15, 20 seconds, so it is a scare that usually gets blown out of proportion, but you should always be ready to deal with complications. Of course, depending on our response to the intervention, we actually can decide how to treat further. So in cases that you actually know that this is an SVT with aberrancy based on your adenosine or vagal maneuvers, then you should actually treat it as an SVT and go back to the algorithm Dr. Munir was discussing earlier. So you have the diagnosis now, you can actually treat it as an SVT regardless what the wide complex looks like, except if it's pre-excited, and that is a different conversation that we will have also at a different time. And if it is a wide complex tachycardia that does not respond to adenosine or vagal maneuvers, then we have to assume that it's VT. Are there medical students here? Or, so there is one medical student. I do remember when we actually were in medical school and we had surgical recall, the book. Maybe it doesn't exist anymore. But there was a question in the surgery section, breast surgery section, that was, what is a breast lump? And it always reminds me of wide complex tachycardia. A breast lump was breast cancer until proven otherwise, which was in the book, which was the wrong answer, but the right management. You always have to assume the worst, especially when it's consequential, and it actually makes a difference how you treat it today, not just today, this second. So in the case of breast cancer, you have to get, the testing within weeks or whatever. In VT or wide complex tachycardia, you don't have that time. So treat it as VT, deal with it later. If you can get information, great. If you can't, just make sure that the patient survives this acute illness, and then we can always deal with it later. Continuous monitoring is very important because there's always the possibility of quick decompensation, even in SVTs. So the patient should always be monitored while they're in this phase, with both ECG monitoring, with blood pressure monitoring, and of course clinical follow-up. This is just a quick response to vagal maneuvers, pretty much the same as adenosine as well, for different kinds of arrhythmias, which I discussed before. I'm going to just skip to the next. Pharmacologic, of course. The treatment for pharmacologic VT treatment, I have to say that there is major, unfortunately, difference between what we have in Jordan and what is available worldwide. I mentioned one of the problems here. Pharmacologic cardioversion options, if the patient does truly have VT, they're still stable, and you actually at least did not prove that they have SVT, you're treating them as VT. The next step is to treat them either with pharmacologic or with electrical cardioversion. Pharmacologic cardioversion includes the two main drugs that we use are amiodarone, which is obviously widely used or widely available in Jordan. The other option is procainamide, which is a really good option, but unfortunately not really available. That's why I put the star. Now, I think that there is a possibility that we can actually provide these medications in Jordan. It needs some work, but certainly we need to at least be cognizant that there are other options, not just amiodarone. And some patients, we have a problem with using amiodarone with, so procainamide can be a good option when it is available. So this is for the sake of completion, and hopefully one day, not too long from now, we will have that option too. And then I'm going to skip the specifics with the dosing for these medications. Now, there are special considerations for patients that have VT with structurally normal heart. There is a VT that I'm sure that a lot of you heard about. It comes with wide complex, but it's still something that we consider low risk VT, like, for example, verapamil sensitive VT or fascicular VT. They can be very sensitive to calcium channel blockers, which you can use that with them, of course. And of course, if you actually are aware of the same tachycardia before responding to a certain medication safely, then you can always do that. Now, if other antiarrhythmic drugs can also be used, obviously, if it's successful, always consult with a cardiologist or an electrophysiologist. That would be very helpful. Otherwise, when you actually have made the determination that this is a VT, always...
We are beyond time. We are 2 minutes beyond time.
Sure. So you always have to actually be cognizant that there are underlying conditions that you have to treat, especially with VTs, like electrolyte abnormalities or ischemia is an important one, in addition to toxins and drugs. I'm going to skip the adenosine. This is the same algorithm that we actually discussed before, and this is just sort of hopefully what the workflow will be when we actually publish it from the task force from EP. A quick word about patients that actually have pacemakers and defibrillators. I'm not going to actually go from the slides, but two things that you have to be aware of. Patients with pacemakers have the same risk for VTs or the wide complex tachycardia that other people have. The only difference with pacemakers is that some pacemakers can actually cause wide complex tachycardia by pacing. And this is easy to actually differentiate with the magnet function. If you actually apply the magnet on the pacemaker, you will terminate anything that the pacemaker is causing, especially PMT and pseudo-PMT, or what we call non-reentry recurrent or repetitive VA synchrony. But basically, the magnet application on the pacemaker will actually help with that. And then the second consideration is or wide complex tachycardia with patients with ICDs. These are high-risk patients already. The index of suspicion should be much higher, and you should always treat them as VT until proven otherwise. And again, magnet application, and Dr. Munir actually drew my attention to this. It should be very clear that magnet application in ICDs does not affect the pacing function, and if anything, it actually disables the ICD function. So magnet application in someone who has wide complex tachycardia with no shocks is the wrong management. If someone has an ICD, consult with an AP or at least a cardiologist to make sure that you're doing the right thing. And I think this is it.
Okay, thank you, Dr. Laith. I think we have a break now. Yeah, coffee break, 10 minutes. Thank you.